You know, when someone tells you they're double jointed, it usually happens in the middle of a conversation, almost like a casual party trick.
Yeah, exactly. It's just a fun thing they do.
Right. They'll hold up their hand, grab their thumb, and like casually bend it all the way backward until it lies completely flat against their forearm. Or they'll lock their arms out and their elbows hyperextend to this impossible backward angle.
And people gasp. They laugh.
Yeah, we tend to view that flexibility as a net positive, right? Like a biological bonus that begins and ends strictly at the joints.
Oh, absolutely. It's seen as a totally localized, harmless quirk of human anatomy.
But what if that simple party trick is actually a glaring, flashing clue? A visible sign that the structural blueprint of your entire body is written in a completely different language. Today, our mission is to answer a very specific and genuinely fascinating question for you. Can hypermobility spectrum disorder cause vaginal laxity?
And to get to the absolute bottom of that question, we are pulling from a really specialized, diverse stack of sources today.
We're looking everywhere for this one.
We are. We're looking closely at clinical insights from physiotherapy clinics that specialize in this exact intersection, places like pelvics and not just bendy.
And some heavy medical journals too, right?
Right. We're diving deep into peer-reviewed urogynecology journals. And because the treatment landscape is so fiercely debated, we are also examining some very intense FDA safety warnings alongside clinical guidelines from regulatory bodies like NICE in the UK.
Okay, let's unpack this. Because to understand vaginal laxity, we first have to take a look at the foundational building blocks of the pelvic floor itself. We have to look at the actual cellular mechanics of being double jointed.
Right, so the terminology you see everywhere in these sources usually refers to a specific group of conditions. Most notably, Ehlers-Danlos syndrome, specifically the hypermobile type known as HEDS, and hypermobility spectrum disorder, or HSD.
Which for decades, medical textbooks considered to be incredibly rare.
Yeah, they thought it was an anatomical anomaly you might only see like once in a career. But the data tells a completely different story now.
Wait, really? How common is it actually?
Well, a recent Welsh population study analyzed nearly 1.7 million health records, and it put the diagnosed prevalence at around 1 in 500 people.
Wow. And even that 1 in 500 figure is almost certainly a massive underestimate, right? The sources note that this condition is chronically under-recognized in general practice.
It is, yeah. And when clinicians actually do suspect it, they use something called the 9-point Baton score to screen patients.
That's the one where you get points for bending your thumb to your forearm or hyperextending your knees or elbows past a certain angle.
Exactly, or placing your palms completely flat on the floor without bending your knees.
Looking at that list, I mean, it just seems like a random assortment of party tricks. Why those specific joints?
What's fascinating here is that the root issue isn't just loose joints, and those specific joints are not tested by accident.
Oh, they're not.
No, the Baton score specifically isolates areas where the joint capsule is highly leveraged and relies heavily on connective tissue for stability. The test is searching for a fundamental, microscopic difference in collagen.
Because collagen is the most abundant protein in the human body.
Precisely. Think of it as the biological glue. It's the raw structural scaffolding that forms your skin, your ligaments, your blood vessels, and crucially, for our question today.
Your pelvic supports and vaginal walls.
Exactly.
So the issue goes far beyond a flexible elbow. It's like trying to build a massive suspension bridge. But instead of using rigid, high-tensile steel cables, the construction crew used bungee cords.
That is a perfect way to visualize it.
Because the pelvic floor is basically a complex hammock made of muscles, ligaments, and connective tissue. Its entire job is to hold up heavy organs against the constant force of gravity.
Right, the bladder, the bowel, the uterus. And if the foundational blueprint of that hammock is drawn with elastic ink, everything changes.
The structural integrity just isn't there.
No. The passive stabilizers within that hammock, the ligaments made of this elastic bungee cord collagen, they simply cannot provide the rigid, unyielding support the pelvic organs require to stay in their optimal positions.
So they just begin to sag under the weight.
They do. They physically stretch.
Here's where it gets really interesting. If a listener has connective tissue that is literally defined as lax or loose, how can a doctor diagnose their pelvic floor as being too tight? Aren't those opposites?
It sounds entirely contradictory, I know.
Yeah.
but you have to separate the passive structural tissue from the active muscular system.
Okay, because if my biological bungee cords are sagging, I would logically assume everything down there is incredibly loose.
And you absolutely have structural laxity, meaning the actual vaginal walls and the connective tissue have lost their tone, they are physically stretchy, and they're failing to hold the organs securely.
Right.
But your nervous system is incredibly perceptive. It immediately senses that the bladder and uterus are not secure. It recognizes that the passive support system has failed, and, well, it panics.
Oh, so it overcompensates.
Exactly. To compensate, the brain actively recruits the pelvic floor muscles to step in and do the job the ligaments were supposed to do.
Wow. The muscles are forced to pull double duty. They are trying to act as a muscular hammock and a rigid ligament at the exact same time.
And muscles are biologically not designed for 247 static loading. They are meant to contract and release.
But to keep the organs from dropping, they can't release.
Right. They end up working overtime, constantly clenching in a desperate attempt to hold the joints and organs together. This sustained, low-grade guarding creates what clinicians call the hypermobility paradox.
The hypermobility paradox.
Yes. The result is a hypertonic pelvic floor. The muscles become overtight, locked in a state of constant spasm, and they literally cannot relax.
That sounds agonizing.
It is. In fact, the clinical studies in our sources show a hypertonic pelvic floor is found in up to 63% of patients presenting with chronic pelvic pain.
The physical toll of that paradox sounds absolutely brutal for the patient. You have someone whose back is in knots, their pelvic floor feels like a clenched fist, they're living with chronic pain, and yet their clinical diagnosis is hypermobility.
It's incredibly frustrating for them. A large international survey of HEDS patients highlighted just how severe this gets.
What did it find?
It found that 64% of respondents reported dyspareunia, which is intensely painful sexual intercourse.
Because the hypertonic muscles compress the nerve endings, causing sharp pain.
Exactly. And on top of that, the stretchy connective tissue itself is genuinely more fragile, leading to reports of spontaneous vaginal tearing and skin splitting during normal activities.
The cascading effects must touch almost every bodily function. Because if the pelvic floor literally cannot relax its vice grip, I imagine things like using the restroom become an ordeal.
Severe chronic constipation is incredibly common in this population. The muscles simply refuse to let go to allow stool to pass.
Creating a vicious cycle of straining against a locked door.
Right, which just further damages the fragile connective tissue.
The desperation for relief in these scenarios is profound. A patient goes to their doctor feeling a sense of heaviness, experiencing urinary leakage because their organs are shifting, sensing that structural looseness.
And the standard medical advice for decades has just been,
You just do Kegels.
yes. The reflexive answer given to almost any woman with pelvic floor complaints. They are told to actively squeeze and tighten the muscles.
Which makes no sense here. If a muscle is locked in a constant spasm, it's already exhausted.
It is starved of oxygen because the constant contraction restricts blood flow.
So actively contracting it even more through a Kegel exercise seems like throwing gasoline on a fire.
Telling someone with a hypertonic, hypermobile pelvic floor to do Kegels is prescribing the exact opposite of what their muscular system actually needs. It accelerates the dysfunction and significantly increases the patient's pain.
So what do they actually need to do?
Patients with hypermobility spectrum disorders often do not need strengthening protocols first. They need what specialized physical therapists refer to as down training.
Down training.
Yes, it involves a highly nuanced process of learning how to consciously disengage the pelvic floor. Therapists often use diaphragmatic breathing techniques to hack the parasympathetic nervous system.
Sending safety signals to the brain to release that chronic, panicked guarding.
Exactly. The muscle must learn how to fully relax and receive fresh blood flow before any strengthening can safely occur.
The delicate balance required to treat a hypertonic muscle wrapped around lax connective tissue is difficult enough on an average Tuesday, but that balance is completely upended during the ultimate mechanical stress test for the pelvic floor, which is childbirth.
It is the ultimate test.
We know that traumatic vaginal births, or delivering multiple babies, are major, well-documented risk factors for developing vaginal laxity later in life. Applying the immense physical pressure of labor to connective tissue that is already fundamentally vulnerable seems like a recipe for anatomical disaster.
The broader data certainly reflects that concern. Scoping reviews and meta-analyses consistently show that women with joint hypermobility have roughly a twofold increase in the odds of developing pelvic organ prolapse over their lifespan.
Where the organs actually descend into or even outside of the vaginal canal. But the clinical research in our stack of sources contains a massive, unexpected twist. The data on childbirth for hypermobile women isn't just a straight line of catastrophic damage.
This raises an important question about how we interpret biological risk across different scenarios. While the overall long-term risk of prolapse might be elevated, there is a remarkable study by Dr. Lise Knopp.
Right, published in the International Urogynecology Journal.
Exactly. She looked specifically at acute childbirth outcomes for hypermobile women.
Wait, earlier we established that stretchy connective tissue leads to a hypertonic pelvic floor and structural sagging. Logically, forcing a baby through that fragile, tense tissue should shatter it.
You would think so, but Knopp's data shows the exact opposite.
The exact opposite.
Her study found that women with benign joint hypermobility actually required significantly less operative intervention during the second stage of labor.
They were far less likely to need a cesarean section after reaching complete dilation.
Right, and they rarely required operative vaginal deliveries using forceps or vacuums.
Why is that? What's the biological mechanic there?
The second stage of labor is the active pushing phase, where the fetal head must navigate the pelvic floor musculature and stretch the perineum. For a non-hypermobile person, that tissue can sometimes act like a rigid barrier.
And under intense pressure, it can snap.
Much like a rigid oak tree shattering in hurricane winds.
Oh.
But the hypermobile tissue behaves differently. It acts like a willow tree in that same storm.
Oh, I love that analogy. A willow tree bending in a storm perfectly visualizes the biological advantage here.
It bends deeply instead of breaking. It yields to the mechanical force.
The extreme elasticity facilitates the passage. It's wild to think that the very same trait causing chronic pelvic pain and joint instability in daily life becomes a massive biological superpower in the highly specific scenario of pushing a baby out.
The numbers detailing that protective effect are truly staggering. The study found these women were significantly less likely to experience a severe anal sphincter tear. The odds ratio was 0.19.
An 81% reduction in the odds of suffering a devastating fourth-degree tear compared to non-hypermobile women. That isn't just a slight statistical anomaly, that is a massive anatomical safeguard.
Furthermore, Knopp's research tracked these patients and found no increased association with pelvic floor disorders 5 to 10 years post-delivery when compared to the control group.
But wait, the broader data showed a twofold increase in prolapse overall. Why the conflict?
The data conflicts because HSD is a broad, complex spectrum. Individual presentations vary wildly.
I see.
One person's specific collagen matrix might heavily predispose them to severe prolapse, while for another, that exact same flexibility prevents acute tearing during birth. The tissue behaves unpredictably depending on the specific mechanical stress applied to it.
Unpredictable is the perfect word for this condition. So, what does this all mean for you? If a listener is dealing with symptomatic vaginal laxity, stress incontinence, or a feeling of heaviness, and specialized down-training physiotherapy isn't fully resolving their symptoms, what is the next step?
Well, when patient desperation meets a lack of clear, easy medical answers, we enter the Wild West of vaginal rejuvenation.
The Wild West is right. The explosion of energy-based devices marketed for these exact symptoms over the last decade has been unprecedented.
It really has. Clinics are heavily utilizing CO2 lasers, such as the new V, and radiofrequency devices like VVEV.
To understand the controversy, we have to look at the intended mechanism of action. These devices apply controlled thermal energy, heating the vaginal mucosal tissue usually between 45 and 60 degrees Celsius.
Right. It sounds a bit like getting a cosmetic laser facial to boost collagen in your cheeks.
But obviously we are talking about infinitely higher stakes here. The internal anatomy of the vaginal canal is incredibly delicate, densely packed with nerves, and structurally vital.
The goal of applying that heat is to create targeted microdamage. The human body perceives this thermal trauma as a wound and triggers a massive fibroblastic response.
It sends inflammatory signals and rushes raw materials to the burn site.
Exactly, to lay down a new, denser matrix of collagen. Theoretically, this tightens the vaginal walls, improves moisture, and restores tone.
Theoretically. But if my pelvic floor muscles are already in a constant spasm and my tissue is physically tearing because my fundamental collagen blueprint is flawed from birth, introducing a localized burn might not lay down healthy elastic tissue.
That is the core of the danger.
I can entirely see why a patient, exhausted by incontinence and pain, would risk an unproven laser out of pure desperation. But the FDA is waving a massive, unavoidable red flag here.
The regulatory pushback has been extremely severe. Former FDA Commissioner Scott Gottlieb issued a highly publicized, stern warning.
Yeah, explicitly stating that the agency is deeply concerned women are being harmed by deceptive marketing and the use of unproven energy-based devices for what the industry vaguely terms vaginal rejuvenation.
And the clinical overviews back up that regulatory concern with some genuinely terrifying case studies. We looked at a comprehensive overview by NICE, the National Institute for Health and Care Excellence in the UK.
What did they document?
They documented severe adverse events where the biological response to the laser went horribly wrong. In one case, a 68-year-old woman developed a crescent-shaped fibrous band directly across her mid-vagina after laser treatment.
Wow. The thermal damage didn't gently tighten her tissue, it created a rigid wall of scar tissue.
Yes, that literally caused a partial obstruction and stricture in her vaginal canal. Another documented case involved a 55-year-old woman who experienced severe, progressively worsening insertional pain and moderate levator antispasms.
So after 3 laser treatments, the heat trauma sent her already vulnerable pelvic floor muscles into out-of-control, painful spasms. The structural tissue damage and the neurological reaction can be profound and permanent.
It really can.
But ensuring we keep our lens entirely impartial on this debate, there's a very vocal counterargument from the clinics performing these procedures and from established medical societies.
There is. Organizations like the Women's Health Clinic, or TWHC, and the British Menopause Society push back extremely hard against the FDA's blanket condemnation of the technology.
What's their main argument?
Their argument rests heavily on separating the specific medical tool from the person operating it. They point out that CO2 lasers actually possess a 35-year safety record in gynecology when used for specific mucosal treatments.
So they argue that the laser itself isn't the inherent danger.
Exactly. They say the danger arises when complex medical procedures are commodified and performed without rigorous anatomical understanding.
Right, TWHC argues that it is complete and utter madness to allow non-medical estheticians, practitioners who might have zero formal background in gynecology to insert laser heads into a patient's vagina.
Their claim is that when the procedure is performed by highly trained, medically led professionals using strict patient screening protocols, the risks are heavily mitigated.
And the benefits for laxity and incontinence are genuine.
From a regulatory standpoint, they highlight that the UK deregulated cosmetic lasers back in 2008, a decision based on a calculated risk-to-benefit analysis.
So they think regulatory agencies should police false claims but not stifle innovation entirely.
Right. They shouldn't remove a patient's right to make an informed choice about a device that aims to stimulate collagen production.
It perfectly encapsulates how incredibly difficult it is to navigate chronic, invisible conditions as a patient. You have the FDA issuing severe warnings about life-altering scar tissue on one side, and clinics pointing to successful patient outcomes and operator error on the other.
If we connect this to the bigger picture, returning to our core question, can hypermobility spectrum disorder cause vaginal laxity? The answer is an unequivocal yes.
The fundamental differences in the collagen blueprint make the connective tissue inherently more lax.
But the critical takeaway is that your body's neurological response to that laxity is often to clench the pelvic floor muscles so tightly that they become aggressively hypertonic.
You feel tight, stiff, and in debilitating pain, even though the underlying architectural structure is loose.
Understanding your specific tissue type is exactly what empowers you in a doctor's office. If you know you have HSD or EDS, you can advocate for yourself.
You can refuse the generic just do Kegels advice. You can seek out trauma-informed physical therapy that focuses on downtraining and breathing to address the muscular spasms.
Long before ever considering surgical interventions or navigating the controversial world of laser treatments, it demands highly personalized care that respects the unique mechanics of a hypermobile nervous system.
Rather than accepting generic, one-size-fits-all treatments designed for people with standard connective tissue, which leaves us with one final fascinating biological irony to think about. We mentioned earlier that the Baton score, that 9-point flexibility test, actually adjusts its scoring parameters based on age.
It does. It does this because human joints naturally stiffen up as we get older.
The connective tissue universally loses some of its elasticity over decades. So if the aging process causes hypermobile people to naturally lose some of their extreme flexibility, could growing older actually stabilize some of their pelvic floor symptoms?
It is a brilliant physiological puzzle Does the natural stiffening of age finally provide the rigid stability those bungee cords have been searching for their entire life?
Or does the postmenopausal drop in estrogen, which we know causes severe vaginal atrophy and its own dramatic loss of collagen, simply replace one connective tissue crisis with an entirely new one? It makes you wonder if that fun party trick of bending your thumb back in your 20s is just the opening act of a lifelong, deeply complex negotiation with your own biology.